Hi everyone, very good evening. Am I audible as well as visible? If I could get a quick nod. I'm sorry for this slight delay. There was a small technical issue which we seem to have sorted now. So yes, a quick nod from all of you in the live chat box, and then we can begin without any further delay. So all of you know that Tuesday 8 p.m. as all of you wanted a session on the histopath images of the bone tumors. So yes, that is what we are going to discuss today. A topic which we don't usually touch upon, but yes, somewhere you must have seen that in all your entrance exams, one question here or there does sneak in from bone pathology histopath image. So today we are going to sort the same. And you know that we are primarily going to focus on the bone tumors, but I've got a few non-neoplastic lesions also that you should pay attention to. So yes, let's begin. I suppose, is the audio video good? Okay, I've got the nod. So many of you might be new, so you know, most of you, I know you've been with me over these sessions, so you know that there's a live chat box, and any query, any question or any form of interaction, we use that, right? So let's begin. With the first thing, you know that we are going to start off, we are talking about the bone. So you know that bone primarily comprises of these trabeculae. These are the bony trabeculae, right? These pink color are the bony trabeculae. And then in between the bony trabeculae, what you have is the bone marrow. So all of this area, this is the bone marrow. So obviously bone marrow is for discussion during hematology. But how can I also show you a picture of bone marrow related pathology? I will talk about it right in the end. But primarily my focus is going to be on the bony trabeculae and what are the tumors that can arise. So before I go on to the tumors, we always must know our basic cells very, very well. So if you look at any bony trabeculae, for example, this pink color, this entire pink color bony trabeculae, if I try to focus on this, you see two types of cells lining these trabeculae. Lining the bony trabeculae, you see two types of cells. One are the mononuclear cells, means they have only one nucleus, and the other are these giant cells. These are the giant cells because they have multiple nuclei. Yes, is everyone able to appreciate that? So the single nucleus ones are known as the osteoblasts. They are the osteoblasts because they are going to form the bone. Osteoblast is going to form the bone. And on the other hand, we have these multinucleated cells which are going to break the bone, and these multinucleated cells are known as osteoclasts. So these are the two types of cells, mononuclear and multinucleated. So can you tell me, or a quick question if I ask you, osteoclasts are multinucleated giant cells. What do you want to call them? Physiological giant cells or pathological giant cells? Physiological giant cells or pathological giant cells? Obviously, they are normal giant cells of the body. Physiological giant cells. Physiological giant cells. So, if I have to make a quick list of the physiological giant cells of the body, who's going to help me make this list? Physiological giant cells, which are giant cells which are normal, which are normally seen. Number one, we've already discussed, that is the osteoclast. What else? What else? Some, osteoclasts are in the bone, and in the bone marrow also we have physiological giant cells, and those are known as megakaryocytes. Those are known as megakaryocytes. Number three, any giant cell that you see in the placenta formation. Okay, I've got one answer, that is megakaryocytes by Dr. Akriti. That is great, and Dr. Vikas has mentioned the third one also. That is syncytiotrophoblast. Placenta, syncytiotrophoblast. Yes, so these are all normal giant cells, physiological giant cells. Someone in between mentioned Langhans giant cell. No, Langhans is the one that you see in tuberculosis. So that is not physiological, that is pathological giant cell, right? Okay, so osteoclast is one of our physiological giant cells. Let's move forward. Okay, so I'm trying to show you another very, very high magnification of the bony trabeculae. So here, if I take this as the edge of the bony trabeculae, what do you see? You will say, one, I'm seeing a cell which has only one nucleus. What do you want to label the mononuclear cell as? Osteoblast. Then you're seeing this big cell which has multiple nuclei. What do you want to label it as? Osteoclast. And in the bone, can you see these cells? Can you see the cells in the bony trabeculae which are in this sort of a lacuna? Yes, this is the osteocyte. So someone in between was asking me about the osteocyte. So here you have the osteocyte. Okay, I've got another one from a fellow student regarding Hofbauer giant cells. Yes, Hofbauer is not a giant cell. Okay, Hofbauer is not a giant cell. What is Hofbauer cell? You are right when I was asking you placenta. Hofbauer is seen as in placenta, but what is Hofbauer? Is it a giant cell, or is it just the name of macrophage? Yes, Dr. Tarun, that was your question. That are Hofbauer cells physiological? You're right, they are physiological, but they are not giant cells. They are just macrophages of the placenta, right? So here we were particularly talking about giant cells. That is why I didn't write Hofbauer over here. I hope your doubt is sorted. Let's move forward. So very clearly, the highest magnification here, you can see that the bone is getting broken, resorbed by this multinucleated giant cells. So everyone is clear with the normal cells. Now let's begin our discussion. So you know we are going to focus on the bony tumors, and these are the first 3 bone forming tumors that you have to focus on. Okay, the first 3 bone forming tumors. Ideally, for the first 2 tumors, what have I written? Osteoid osteoma and osteoblastoma. We don't typically get images in pathology. This is more of a theoretical question that you get. What is that size criteria that we have? So I hope all of you know that, when I talk about osteoid osteoma and osteoblastoma, their clinical presentation is different, but their histopath is the same. Their size is different, their site is different. So, but when I come to seeing a slide, that's the same. Both of them are omas, both of them are benign tumors, osteoid osteoma, osteoblastoma, right? So please remember, the first thing is the size. Osteoid osteoma is, now there's a variation. Some books mention 2 centimeters, some even mention 2.5. So osteoid osteoma is less than 2 centimeters. Osteoblastoma is more than 2 centimeters. Osteoid osteoma typically or most commonly occurs in the tibia, the diaphysis of the tibia, and osteoblastoma occurs in the spine. So like I told you that their clinical presentation is totally different. But when I come to seeing the basic histopath, this is first and foremost the radiographic image which will help you analyze the histopath. So if you're well versed with this, you'll be able to see what you see on the slide. You'll be able to correlate. So this was a specimen of, say, osteoid osteoma that has been resected. And of the specimen, you've done a radiographic analysis. Okay, so do you see this radiolucent area in the center? This is known as the nidus. This is referred to as the nidus. Let me tell you that osteoid osteoma and osteoblastoma both show you the presence of this nidus. And surrounding the nidus, you have thickened bone which makes the cortex very, very thick. There is a thick cortical bone. Right? Okay, so now when I try to correlate this with the histopath, so certainly, can you see that if you see both these images, you can very well, now all of you are very well versed with what this structure is. These are the pinkish color bony trabeculae. Yes, these are the bony trabeculae. Let us zoom into them a little. If I zoom into this bony trabeculae, do you all see that the periphery of these bony trabeculae are lined by some cells? Those single nucleus cells, yes, osteoblastic cells. Can everyone see these very nice thick bony trabeculae all around the pinkish color ones that are forming? That these are seen in both osteoid osteoma and osteoblastoma, whereas the center, remember that center, this is the center which is made up of mineralized tissue, it is made up of woven bone. So this is the center which is coming out to be the nidus. This is that nidus, and then do you see surrounding the nidus you have this pinkish color bony trabeculae which are laying down. So you very well have to know the radiographic appearance, then you are going to talk about the histopath. Okay, all the other queries regarding to topics not of this bone pathology we'll be taking up in the end. I see a couple of students putting up some doubts which are not pertinent to bone path, so we'll take them up in the end. We won't bring them up right now. Okay, moving on. So the main tumor, that was only for because Robbins mentioned, so I've shown it to you. Trust me, it's not a tumor I would primarily expect in the paper. This is a tumor which all of you know that is important for your exam. That is the malignant tumor of the bone, osteosarcoma. osteosarcoma. So I guess in radiology you guys have seen this image a couple of times, lifting of the periosteum, resulting in the formation of the Codman triangle. Yes, all of you are very well versed with this image. So you can definitely see a tumor mass over here, very well over here. You can appreciate a tumor mass, an irregular tumor mass, and same radiographically you can see lifting the periosteum. But one thing that you have to see when you have to look at the slide. So yes, when I ask you osteosarcoma, what is the most common site? Either the lower end of the femur or the upper end of the tibia. Yes, is everyone well versed with this much information from orthopedics, I suppose? Lower end of femur, upper end of tibia. But when I look at the slide, I think that is something where everyone gets a little confused. So let us decode the slide, histopath slide first. When I'm saying osteosarcoma, malignant tumor, osteosarcoma, fine. So here you can see some surrounding normal bony trabeculae. And then this area shows you at the most, at this par, you can just say, ma'am, lots and lots of cells I'm seeing. Okay, you can just say that, okay, you're seeing lot of cells. Number one, okay. Let us zoom into that cellular area. I'm zooming into this area, okay. I'm zooming into this cellular area. When I zoom into this area, what are the two things that you're seeing? First, you're seeing these cells which are in between, a lot of these cells, and do these cells look nice and round, or do they look very hyperchromatic, dark in color, dirty looking? As per me, they are very, I can tell you the characteristics. Look, number one, I would want to say they are very, very atypical, that is pleomorphic. What do I mean by pleomorphic? They are very pleomorphic. Some of them are becoming spindly, some of them are becoming big in size, some of them are becoming smaller in size, medium in size. I'm seeing a lot of sizes, a lot of shapes. They are very, very pleomorphic. Look at this one has become big. So they are pleomorphic, right? And do you notice all the nuclei are very, very dark, hyperchromatic. So I'm certainly dealing with a tumor which is very bizarre looking, very dirty looking. And the second component is, in between the two tumor cells, the most important, without which you cannot make the diagnosis of osteosarcoma no matter what, is this pinkish material that is being laid down. So how do you see it? You see tumor cells, and in between the tumor cells you're seeing this pinkish material is being laid down. This is known as osteoid. First, you should know the histopath description of osteoid, and that is, it is thin, lacy, eosinophilic material. Eosinophilic because it is pink, thin and lacy, and some people also call it glassy. And remember, it is these tumor cells which are laying down this osteoid. They are depositing this osteoid. That is why you're seeing the osteoid in between the tumor cells. And without this, you will not on histopath make the diagnosis of osteosarcoma. So all of you know that any bone tumor, we never make the diagnosis only on one thing. Neither will you make it only on radiology, neither will you make it only on gross, and neither will you make it only on slide. So you have to have all the features together. The gross with the radiology and the slide, and what on the slide? Osteoid deposition on the slide. Let me show you some more pictures, because this is the most important bone tumor you have to know. Here also, can you notice some pinkish material is getting deposited in between the cells, in between the tumor cells? Yes. Can everyone appreciate this? Let me zoom in and show you a very high power picture. I think this is the best picture that you can see. You see these really big, huge tumor cells, and in between them you see that lacy pink color osteoid being laid down. That is the characteristic of an osteosarcoma. Yes, is everyone clear? So we've done osteoid osteoma, osteoblastoma, and osteosarcoma. Coming on to the next, cartilage forming tumors. So all of these were bone forming. I was showing you bone, osteoid, bony trabeculae. Now I'm going to include everything with cartilage. So I am going to now show you cartilage forming tumors. The first one is a benign tumor called enchondroma. So let us see a picture. As the word suggests, enchondroma. In fact, let me go opposite and let me first show you a radiographic picture. When I say enchondroma, this is a picture I've taken from Robbins, so that you can also revise when you revise your notes. So can you see that in the phalanx there is a radiolucent lesion that is present. Yes, can everyone appreciate this? In the phalanx there is a radiolucent lesion present. Yes, and in between that lesion you can see some calcification, some calcific deposits are seen. So in the proximal phalanx a radiolucent lesion is seen with little bit of calcification. Number one. Number two, which is very, very important, are you seeing that? Tell me a yes or no. Do you feel, is it breaking the cortex, or is it penetrating the cortex, or is it inside? Is it inside, or is it breaking the cortex or penetrating the cortex? I personally feel it is not penetrating the cortex. I feel it is inside. It is not penetrating the cortex, and that is the most important point about an enchondroma. Permeation should be absent. It's a benign tumor. Permeation should never be seen. So now let's try to correlate. I was seeing a radiolucent lesion. I was seeing a radiolucent lesion because all of that is this blue color cartilage. All of that is this blue color hyaline cartilage. And then I'm seeing some areas of calcification because, let me show you another picture. Can you see this on high power? Can everyone appreciate this blue color hyaline cartilage? Yes? Blue color hyaline cartilage. How do I identify cartilage? Firstly, by the blue color. And secondly, you will always see lacunae. You will see cells present inside lacunar spaces. Yes, that is cartilage. And then I can see some calcification happening. Can you see this this pinkish area? Can you see this calcification happening? So yes, that was probably what I was seeing radiologically also. So yes, this is calcification that is taking place. Are we clear with an enchondroma? Let me show you another slide. Or let me ask you first, do you know of any syndromes with which enchondromas are associated? Yes, a quick question from everyone in the house. A syndrome in which multiple enchondromas are seen and maybe something else is also seen. Who would want to give me a very quick answer to that? So there are two syndromes to be precise, and any one name also would be good to go. Very good. I've got Olliers syndrome and Maffucci syndrome. Very good. Olliers syndrome and Maffucci syndrome, both of them have multiple enchondromas. Both of them have multiple enchondromas, but please remember Maffucci syndrome, you will be studying it in gynecology also, because they additionally show you ovarian tumors. They can show you ovarian tumors. They can also show you gliomas and hemangiomas. They can also show you gliomas and hemangiomas. So please remember, enchondroma is there. Other than that, hemangioma, ovarian tumor and gliomas. Olliers also shows you multiple enchondromas, right? So this was your enchondroma. Enchondroma means inside, intramedullary, inside. You could see it intramedullary, not invading the cortex. Here I could see very nicely the presence of hyaline cartilage, and then I could see calcification. Let's go on to the next one. Osteochondroma tells you the word. I'm going to have a part of bone in this tumor and chondrocartilage in this tumor. And this is a classical picture which you must have seen in Robbins, how these are mushroom shaped. Can you appreciate the growth of these? How these are mushroom shaped. And if you look at them, because if you analyze this picture, you will see the gross also. It's a beautiful gross that you see. It's a mushroom shaped projection. EXOSTOSIS is what you call it. They also call it EXOSTOSIS. And from the EXOSTOSIS, if I take the three alphabets, that is EXT, it is associated with the mutations of EXT1 and EXT2 gene. So EXOSTOSIS. Why? Because it looks like a mushroom protruding out. It's going to have a cap. Do you see the topmost, the one made in blue? That's a cartilage cap. And then you have the bone below it. So you can see the bony projection is in continuation with the main bone, and it is just covered with cartilage. Now please remember this, because when you see the radiology, you will again see that classical mushroom shaped outgrowth. So EXOSTOSIS, mushroom shaped outgrowth, EXOSTOSIS. But when you see this beautiful gross is what I was talking about. It's one of the classical spotters where examiner would not want to give you any history. Again, first and foremost, you see that mushroom shaped nice projection that we have. Okay, and how do I identify cartilage grossly with the naked eye? Can you notice the topmost cap of this tumor, it's glistening. It's glistening, and if you look very carefully, it has this bluish tinge, but the most important point is that it is glistening. So that's the cartilaginous cap, and below it you have the bone. That is an osteochondroma. And don't you think the same thing when I want to see microscopically? Here I see it. Obviously, the cartilaginous cap is showing me that entire blue color hyaline cartilage, and then the bone is showing me these bony trabeculae. So if you know the gross and the radiology well, the histopath is going to correlate exactly with that. You see the cartilaginous cap, and then you can see the enchondral ossification taking place. Is everyone clear with osteochondromas? You agree that it's quite a classic picture. Once you see this mushroom shaped exostosis or osteochondroma, no one should forget it. And what did you learn? Glistening. Glistening is the appearance that you give to cartilage. Okay, moving on. Now we come to another cartilage forming tumor, which was your recent JIPMER paper question also, and that is chondroblastoma. Chondroblastoma. Let me tell you, this is a giant cell containing lesion. Giant cell containing lesions. So I have already encircled two beautiful giant cells for you. So when I'm dealing with chondroblastoma, three things. Everyone has to mug up three things today for chondroblastoma. This was your JIPMER paper theory question, but I'm putting it up as a image based, as an image. They asked you histopath only, but they wrote it as text and gave it to you. I'm asking you as an image based, which is the more expected one. Okay, so here you have these multinucleated giant cells, and if I zoom in, do you see some single nuclear cells that I have also encircled? Do you see something inside them? Do all of you appreciate that this has a line in it? Yes, can you appreciate one line in this single cell? Okay, let me come to this side. Can you appreciate one line in the cell that I've encircled? One line, so there are nuclear grooves. So what does a chondroblastoma have? If I have to put it in one frame, it has giant cells, it has mononuclear cells, and those mononuclear cells show me beautiful grooves. That is point number 2. Who will tell me the third and the most important? Very good, Dr. Vikas, Dr. Ruhan, Dr. Mary, excellent. Third point is it shows us chicken wire calcification. So here we are in between. So what is a chicken wire? It's a fence. It's a fence that they make to stop the chicken, obviously. So it's like a fence that they have made. The fence looks somewhat like this. That's the shape of the fence. So basically, I have a tumor cell. Around the tumor cell, I have calcification. Then I have another tumor cell. Then I have calcification. So calcification is surrounding every tumor cell. Calcification is seen surrounding every tumor cell. Everyone knows the color of calcium on HNE. The color of calcium on HNE is blue. So here you see around every tumor cell, I see bluish outline because that's calcification. Chicken wire calcification. So what does a chondroblastoma show me? Giant cells, nuclear grooves, and chicken wire calcification. Where do I see chicken wire blood vessels? Now this is not related to bone, but it's some other tumor where I see chicken wire blood vessels. What is that tumor? I think everyone will be able to answer this. If not, then I'll give you the hint of the organ. Chicken wire blood vessels. I've given you the picture. You can see these blood vessels that are present. They are anastomosing and they are surrounding the tumor cells. And I'll give you a hint. I have a tumor cell and it has white area around it. I have a tumor cell, it has white area around it. It's a brain tumor. Excellent. I've already got my answer from 7 students. Amazing. This is oligodendroglioma. What was I showing you? This clear area around the tumor cells? Fried egg appearance. I was showing you the fried egg appearance. So please remember, chicken wire blood vessels is seen in oligodendroglioma. And where do you see chicken wire calcification? So that is the tumor we were talking about. Chondroblastoma. Chondroblastoma has 3 things. Giant cell, number 1. Mononuclear cells with grooves, and number 3, chicken wire calcification. Are we sorted? Right? Okay, great. I see a couple of you answered oligodendroglioma, which is amazing. Moving on, coming to the malignant tumor of cartilage. So which were the other ones that we did? We did enchondroma. Then we did that mushroom shaped one, the beautiful osteochondroma. Now we've done this chicken wire one, that is chondroblastoma. And now we come on to chondrosarcoma. It's the same cartilage tumor. It's a malignant tumor, chondrosarcoma. So obviously the cells are going to look very, very dirty. cells are going to look very dirty, and pretty much I guess everyone can, direct picture from Robbins again, everyone can pretty much make out that the cells are no longer small and innocent looking. They are bizarre, they are big, some might even have two nuclei. That is a malignant cartilage cell, a malignant cartilage cell. How do I identify? If someone asks you the exact definition, that how do you differentiate a malignant cartilage cell from a normal one? Okay, so normally you see cartilage cells in a lacuna, right? So there'll be a lacuna and then you will see a cartilage cell, right? However, if you start seeing in one lacuna, you start seeing multiple cartilage cells, multiple cells in one lacuna, and you start seeing multiple nuclei in one cell. So multiple cells you're seeing in a lacuna, that is a very, very strong indicator of a malignant cartilage cell. Okay, when in one lacuna, so like over here, if you want me to highlight, can you see this area? Can you see how one lacuna is studded with so many cells, more than one cells in one lacuna? That is something that you see with chondrosarcoma. So as soon as you see dirty looking cells with more than one cells in the lacuna, chondrosarcoma, definitely. And what is the most important feature that you have to see radiologically to differentiate a benign cartilaginous tumor from a malignant, without which, the radiologist can never sign out the report as a benign or a malignant cartilaginous tumor or a suspected tumor. That one point which has to be there, permeation. Permeation. See, this is a chondrosarcoma, this is a cancer. Permeation has to be present. Permeation has to be present. Is this clear? So that is why in enchondroma, remember in that finger tumor, the phalanx tumor, I was again and again emphasizing permeation is not seen, it is not seen, because that is what, if it is seen, that is what makes it chondrosarcoma. Permeation is the hint out here. Okay, moving on. Everyone's favorite tumor. I don't think I have to teach you this tumor. The classical giant cell tumor. The classical giant cell tumor. So I'm going to zoom into this, and if at all needed, I don't think anyone needs to see this tumor as such, but if you still do, then there you have in front of you. GCT, giant cell tumor. Obviously, what you see are a lot of osteoclastic giant cells. Now, who will answer a very important question for me? See, there are two types of cells I'm seeing out here. One is lots and lots of giant cells, okay? And in between the giant cells, I see cells which have one nucleus, single nucleus. Okay, so which is the tumorous part? Which is the neoplastic part? Is it the giant cells, or is it the multinucleated giant cells, or is it the the mononuclear cells? Which is the tumorous part? Very good. I've already got an answer from Dr. Vikas. Giant cells are not the tumor cells. Exactly. Let me tell you, giant cells come as a reactive component. The tumor cells, if someone asks you, tumor cells kaun se hain? The single nucleus ones, the mononuclear ones are the tumor cells, neoplastic cells. Giant cells are just reactive. So many students ask me when we are discussing chapter 1, chapter 1, chapter 2, inflammation chapter, when we are doing types of giant cells, and we discuss tumor giant cells, many students ask me that why didn't you make us write giant cell tumor over here? Because in giant cell tumor, you can't call these tumor giant cells because they are not the tumorous component, right? The tumorous component is the single cells. So if I have to mark out very clearly, here you see the giant cells, which are the reactive population, and here you see the single cells, which are the mononuclear cells, and the mononuclear cells are the neoplastic component. Are we clear on this? Moving on, everyone's favorite tumor, November 2019 AIMS question, and all of you know that now I think there's no point emphasizing on AIMS, JIPMER or anything, because everything right now an hour ago has come under one roof. So now we are just, whatever may be the exam, we are all headed towards a common goal. So yes, that is something we will talk about and we'll plan up definitely for 20th of November. But here we have a case which came to you in the November exam in 2019. And this was the question that was asked. So this tumor image was given and they clearly asked you the marker. So I think everyone has identified that as soon as you see this picture out here, it's a very blue tumor. It's a small round blue cell tumor. It is a small round blue cell tumor, which is, so I'm going to show you more pictures also. You can see these small round blue cells. Okay. This is Ewing's sarcoma. Ewing's sarcoma, everyone first has to know the translocation. Theory session we'll be conducting obviously separately on Unacademy, where we'll do all the theory points and make summary tables of all bone tumors. Today's session is only for images. But still, Ewing's sarcoma, 1122 translocation. Always have to remember Ewing's sarcoma, E for 11 and S you are going to turn, so 22. Ewing's sarcoma is 1122. Ewing's is 1122, which is the EWS Fly1 fusion. EWS stands for Ewing's sarcoma. So EWS Fly1 fusion. And what is the marker? CD99 or MYC2. Marker is CD99 or MYC2. Right? Okay, someone's asked me, will the PDF be available? Yes, I'll put it up on the group. So no doubt about that. You can just concentrate on the images and hear it out right now. Okay, moving on, what else can you see in this Ewing sarcoma is a beautiful picture that we have out here. So what do we have? We have some tumor cells which are arranged in a round manner and pinkish material in the center. So can you appreciate this round structure out here? Can you appreciate this round structure out here? We have tumor cells which are arranged in a round manner with pink material in center. Round manner, pink material center. Round fashion, pink material center. We call this Homer-Wright pseudo-rosettes. So remember, whenever you have cells arranged like rose petals, okay, in the around circling, tumor cells are circling, and in the center you have some pinkish fibrillary material sitting, that is a Homer-Wright pseudo-rosette. Which other tumor shows you Homer-Wright pseudo-rosettes? Can you tell me till that time, all the students who want this is a proper zoomed in image of Homer-Wright pseudo-rosette, round arrangement of the tumor cells, and you have this classical pinkish material. Yes, so please let me know which all tumors can show you Homer-Wright pseudo-rosette. Very good, Dr. Sharmila. We've got number 1, medulloblastoma. Number 2, come on, medulloblastoma is 1. Then you've got Ewing sarcoma as 2nd. Neuroblastoma also shows you Homer-Wright pseudo-rosettes. Neuroblastoma also shows you Homer-Wright pseudo-rosettes. And excellent, Dr. Mubarak Ali says, ma'am, retinoblastoma also shows. Okay, now I agree with you. Retinoblastoma can show you Homer-Wright pseudo-rosettes. But what is the more commoner rosette that you would expect in a retinoblastoma? Homer-Wright pseudo-rosettes are seen. I take that as an answer. I agree. But is there any other rosette which is not a pseudo-rosette? It is a true rosette which you see in retinoblastoma. Flexner-Wintersteiner rosette. Flexner-Wintersteiner rosette. Yes, that is something. It's a true rosette which you see in retinoblastoma. But yes, retinoblastoma also shows you Homer-Wright pseudo-rosette. So what's our list? Ewing sarcoma. In the brain we've got medulloblastoma. Then we've got neuroblastoma. Then we even have retinoblastoma. Okay, moving on. Now the interesting question that can come. You've done the translocation, you've done the marker. If I ask you the special stain, do you notice some of these cells are a little empty around them? Cytoplasm looks a little scant and it is kind of empty. So any special stain that we can have? Any special stain that we can have? Remember, Ewing sarcoma is PAS positive. Can you all appreciate, I've put a PAS stain out here. And can you all appreciate how the tumor cells have become beautifully pink? Because P for PAS, P for pink. Can you see the cytoplasm has all become pink in color? So PAS is something everywhere. You can zoom around and see nice pinkish color. Nice pinkish color has come up out here. So this is PAS positivity that you see with Ewing's because it contains glycogen. So how would a question come? A question will come like 11-year-old boy. He's come to you with a swelling. And for very few bone tumors, you know, FNAC can be done, or maybe it is extending out. So an FNAC is done. You got cells which were looking small, round and blue. And these cells were found to be positive for PAS. So as soon as you read this, PAS positivity, your first bone tumor that comes to your mind is Ewing sarcoma. Is this clear with everyone? Right? Okay. Dr. Prachi has asked me a question that, ma'am, in ependymoma rosettes, ependymoma, if you remember, yes, you can have both. But you also have perivascular rosettes. Around the blood vessel, they are arranged. That's a very classical rosette that you see in case of ependymoma, right? Perivascular rosettes. Moving on, moving on. Now, this is a very important tumor which we usually miss out on because it's very rare, okay? Very, very rare. And now all those students who are targeting this 20th November, whichever exam you want to call it, this is the kind of a question that you would get in a central institute exam. And if you know this one picture, trust me, you know 3 tumors of the body. 3 tumors of the body look exactly like this, but they've been given different names in different organs. It's very interesting. So first and foremost, when it's in the bone, like in the tibia, you call it adamantinoma. It's a rare tumor. Let me tell you, it's a rare tumor, but it's important for you to know in the central institute exams. Okay. Adamantinoma. What do you see in this tumor? First and foremost, if you notice, you have this layer of cells that is going, blue color layer of cells. Can you trace these all? Can you see how I'm tracing them out? Can you see how I'm tracing them out? Blue color cells, they are all arranged parallel to each other. They are palisading cells. Agreed? Trace them anywhere you want to. See all these nuclei, all of them are lying next to each other. Palisading nuclei. Everyone agrees to this first thing? Palisading nuclei? Okay. Next, do you see this area that I'm highlighting now? Do you see this area that I'm highlighting? Don't you think the cells are a little loose over here? They are not stuck to each other. They are a little loose. Then see the area that I'm highlighting over here. Do you see this area? Do you see this area? Do you agree that the cells are a little loosely arranged? This is known as stellate reticulum. So what are the 2 population of cells that I've shown you? Number 1, palisading cells, and number 2, stellate reticulum. Someone gives you this image. Immediately you ask him, tell me the site. If the person says site is tibia, you say my answer is adamantinoma. If the person says the site is tibia, your answer is adamantinoma. If the person says the site is a jaw swelling, ameloblastoma, these are all separate tumors. Site makes all the difference. They look exactly the same on histopath. All of them have palisading cells. All of them have stellate reticulum. So in the tibia, you call it adamantinoma. In the jaw, you call it ameloblastoma. And can you imagine suprasellar brain tumor, suprasellar tumor in the brain? Same, it shows you the same morphology. Have you all seen craniopharyngioma? Yes, Dr. Shrishti, amazing. Amazing if you got that differential diagnosis right. Craniopharyngioma in CNS, ameloblastoma in the jaw, mandible, exactly, and adamantinoma in tibia. All 3 of them, same picture, copy paste. So no matter what picture I show you, same picture I'll show you, I'll have to give you the site. I can't expect you to guess it on your own. I'll give you a site of tibia, jaw, or CNS. That depends. Okay, moving on. Coming to the recent most favorite question. So now we've kind of, moved a little away from the bone tumors. I'm not finished with the tumors as yet, but this is one picture which is such a spotter, beautiful picture that is given to you in Robbins if you see. And this is something that again I would want you to learn for your Central Institute exam. I've shown you, you'll say, ma'am, it looks just like any other picture that you've shown me. I see bony trabeculae, these pink color bony trabeculae I'm seeing. And in between, I'm seeing fibrous tissue. But you missed out on the shape of these bony trabeculae. They all have this weird shape. They are not like what I had shown you earlier. Some of them are C-shape. Some of them are like a fish hook. So C-shape or a fish hook. Then they have different letters that they are trying to make. Different letters that they are trying to make. Curvilinear. So many names have been given to them. This is a case of fibrous dysplasia. So this is a kind of a maturation defect. It's a kind of a maturation defect, and you will see that the bony trabeculae have this curvilinear. So you can call it curvilinear, or you can call it fish hook because it is forming these C-shaped bony trabeculae. Some people also call it Chinese letter appearance. Okay, which bacteria shows us Chinese letter appearance? That also shows you this V, L, and so on and so forth. Yes, so which is the one? It is Corynebacterium diphtheriae. Everyone remembers that also shows us, right? This V, L, different type of Chinese letter pattern. Yes. Similarly, Chinese letter pattern is seen in fibrous dysplasia also. Okay, so if I zoom in, I can show you much better. Can you see the curvilinear bony trabeculae? curvilinear bony trabeculae, and in between I have all fibrous tissue. Okay. Do you know of any syndrome with which fibrous dysplasia is associated? Any syndrome with which fibrous dysplasia is associated? So I guess I had Dr. Mubarak Ali already mentioned that earlier. I was reading, it is McCune-Albright syndrome. It is McCune-Albright syndrome. In this, you see the presence of fibrous dysplasia. Fibrous dysplasia. But the story is not over. Okay, the story is not over. One most important feature I still have to show you. So you've learned that Chinese letter hai, fish hook hai, curvilinear hai. You know all of that. Now I'm going to zoom in further. What I want to show you is when you see, like for example, see this, just see the tiniest bony trabeculae that you can. Okay, the tiniest one, just have a look at it, and we'll zoom in also. Okay, we'll zoom in also. Can you see that normally I was showing you, see both of these, see any of these. Normally what was I showing you? That the entire rim is going to have osteoblasts. Remember I told you bone forming osteoblasts are going to be present. Yes, osteoblasts are going to be present. But over here I see no osteoblastic rimming. Osteoblasts are not there. Similarly, in this area, just look at the edge of the bony trabeculae. Where are the osteoblasts? They are not there. Just the edge, they are not there. Okay, again, look at this edge, they are not there. No osteoblastic rimming. You know why is that important? Let us trace this also. Again, I'm not seeing the osteoblasts. Empty. Because this you have to differentiate from something known as non-ossifying fibroma. Let me tell you, number one, there is something known as fibrous dysplasia which we were studying. That shows you these fish hook pattern and everything. And will you see osteoblastic rimming? You will not. What is the differential diagnosis of fibrous dysplasia? What can it very closely mimic? On low power, what else can also show you that Chinese letter pattern? Non-ossifying fibroma can also show you. But when you go high power, can everyone appreciate around every bony trabeculae? Can you see a row of cells which is lining? Can everyone appreciate the osteoblastic rimming? All these trabeculae, see a line of cells I can see are seen rimming the bony trabeculae. Osteoblastic rimming is present. Yes, are we clear on this? Sorted up till now? Fibrous dysplasia, no osteoblastic rimming, non-ossifying fibroma, osteoblastic rimming is present. I hope that is okay with everyone and we can proceed. Okay, coming on to the next and another very rare lesion but important. The word tells you everything about it. Aneurysmal bone cyst. Aneurysmal bone cyst. Now let me tell you, my purpose of carrying out this images decoded session today on bone path is that having done this, you are all familiar with all the terms that you have to know in bone, you are familiar with all the images, and in the coming 1 or 2 weeks, I'm going to conduct a special class on bone pathology MCQs on Unacademy. So then that time we can focus on all the theory that is important for the exam, and then we won't have to waste any time on the images because then we are very well versed with images and questions related to it. So we'll only have to focus on the genetics, the location, the other miscellaneous syndromes, findings, so on and so forth. So the purpose of this is you should be very crystal clear with your images first. Okay, aneurysm. Aneurysm will always remind you of a blood vessel. So can you see you have large dilated blood vessels over here? You have lots. See, I can see a lot of blood. I can see a lot of reddish color blood. I can see these vascular channels. So you will see these vascular channels. And you know these vascular channels will be lined by giant cells. That's the characteristic property of an aneurysmal bone cyst. You can see multinucleated giant cells. You can see multinucleated giant cells which are lining the dilated channels, the blood vessels. So you can see them lining. So here, can all of you appreciate these cells? Can everyone appreciate clustering of these cells around the blood vessels? Yes. So this is the aneurysmal bone cyst. So we are doing a couple of giant cell lesions. Remember these for your theory sessions, okay? One we did giant cell tumor. Then I told you this aneurysmal bone cyst. Then do you remember any cartilaginous tumor where we were seeing a lot of giant cells? Yes, where we were seeing a lot of giant cells. That is other than obviously what I've told you. Any cartilaginous tumor, giant cells with chicken wire calcification, chondroblastoma. So a lot of giant cell lesions we are doing today. Giant cell tumor, then we've done aneurysmal bone cyst, we've done chondroblastoma. These are questions you get, MCQs that you get in the paper, PGI type of pattern. What are the giant cell containing lesions of the bone? Okay, moving forward. I think everyone knows the disease that I'm showing you towards the end. I'm seeing sclerotic bone with multiple cement lines, and I'm seeing some cracking in between. I've given you all the points. I've seen these multiple cement lines, these lines that we are seeing over here, these are known as cement lines, and they give a jigsaw or a mosaic kind of pattern. And I can see a little bit of cracking, these empty looking cracking artifact also I can see. Which disease am I talking about? Come on, everyone needs to know this. This is the first disease that we study under bone. It was non-tumorous, so I put it up in the end. What is that? No answers up till now? Very good. Got the answers, Dr. Rahul, Dr. Pooja. Very good. Paget's disease, guys. Paget's disease. What does Paget's disease show you? So if you remember, obviously this is not a theory session, but if you remember, when Paget's disease starts off, it starts off as an osteolytic phase, where you'll see a lot of osteoclasts coming and breaking the bone, osteolytic. Then there is a mixture, lytic-blastic mixture phase. And then there is an osteosclerotic phase where you see this, you see multiple cement lines, you see these cracking artifact, and those multiple cement lines give it that mosaic or a jigsaw pattern. This is the third jigsaw that we are doing in pathology. We've done 2 more jigsaw lesions earlier. Quick revision on that. Quick revision on the jigsaw lesions. Quick revision on the jigsaw lesions. One is okay, I'll give you a hint. One is a lesion of the liver, one is a tumor of the skin, and third jigsaw pattern is seen in Paget's disease of the bone. So yes, I'm waiting for the other two. Come on, no answers. We've done this so many times. Very good. Dr. Vikas has given me the first answer, that is biliary cirrhosis. Okay, one. Okay, so we'll write it. Where all do we see the jigsaw pattern? Where all do we see the jigsaw pattern? Number 1, we see it in biliary cirrhosis. So if you don't know this, you have to go and see images decoded of liver chapter. Biliary cirrhosis. Number 2, we see it in a skin tumor. Excellent. I've got the answer. Dr. Madhushri, great. Cylindroma. What is it also known as? Cylindroma occurring on the scalp. Multiple cylindromas on the scalp. Excellent, Dr. Vikas. That is turban tumor, right? And number 3, where do you see the jigsaw pattern? It is in the Paget's disease of the bone. I am again and again emphasizing Paget's disease of the bone. Why? Is there any other Paget's disease also which I can confuse this with? Is there any other Paget's disease also with which I can confuse this? This is Paget's disease of bone, but any other Paget's disease that we are missing out on? Okay. Yes, 2 more organs which show you Paget's disease. 2 more organs which show you Paget's disease. As you see over here. Have you heard of Paget's disease in the breast and vulva? In breast and vulva. So they are totally unrelated. This was Paget's disease of bone, and that is Paget's disease of breast and vulva. So I've got you an image from the Paget's disease of breast. And very clearly you can see this is a section from the skin. So never confuse, these are 2 separate entities, okay? So remember, this is a section from the skin, and here you can see some kind of clear looking cells that have infiltrated into the skin. So see, it has nothing to do with bone. This Paget's disease is totally different. So you can see some clear looking cells which are coming into the skin, right? Why? Because in the breast, since I gave you example of breast, somewhere underlying patient has a malignancy. And these are the cells that have come up over here. So can anyone tell me what are the special stains? I know I'm taking you to an altogether different chapter, but it is very important to know. So these are all known as Paget's cells. Can you tell me these clear looking cells will be positive for which stains? What are the special stains for it? Special stains. So that is how you will recognize Paget's cells in breast, in vulva, same stains. They are positive for, come on, exam going students, you have to answer this. I know you know the answer. There are some stains, and there are good mixture of stains that you see. They can be positive for mucicarmine. They can be positive for Alcian blue. They can be positive for Alcian blue. No answers as yet. And please remember, they are also CK7 positive. They are positive for MUSI carmine, they are positive for Alcian blue, they are also CK7 positive. Yes, very good. They are also PAS positive. Very good, guys. They are also PAS positive. So like I told you, there's a whole mix of special stains that you've got for them. PAS, MUSI carmine, Alcian blue and CK7. Very good. I finally got the answers from each one of you separately. Amazing. So this page it's disease and that page it's disease, totally different, right? Okay, coming on to the second last tumor for the day. Yes, anyone who needs to, I've taught you this earlier also, I'll give you a hint. This is a sacrococcygeal mass in a child, for example, a sacrococcygeal mass, and that's actually a very important site. A sacrococcygeal mass. All three photos are the same. They are from the same tumor. I've just got you different photos so that we can discuss and you'll never forget it. As soon as I said sacrococcygeal mass, you should have anyway answered it. Very good, Dr. Shrishti. This is a chordoma. So let me explain that to you. Okay, just because I said sacrococcygeal mass doesn't mean teratoma. Teratoma, if you would have called it teratoma, you would have seen different germ layers. You would have seen something like hair or teeth or some other organ formation happening. So here you're not seeing that. What you're seeing over here, first and foremost, agree with me, background looks very blue. The background of this slide, it looks very blue because there's a lot of myxoid material present. Very blue background. Okay. Other than that, when I see the cells don't have a proper cytoplasm. If you zoom into any one cell you want to zoom into, we classically describe them as bubbly looking. So do you look at this? It looks as if there are some bubbles inside it. There are some vacuoles, there are some bubbles. So you don't see that nice cytoplasm. Look at this cell now. Look at this cell that I've encircled. There's a blue color nucleus and cytoplasm has multiple bubbles. So it's the bubbly cytoplasm. That is the classical appearance of a chordoma. Classically presents in the sacrum. And you call these bubbly looking cells as ficelliferous cells. Maybe all of you have seen a one-liner question in the previous years. Ficelliferous cells are seen in. So remember, these are the bubbly looking cells and these are the cells that you see in a patient of chordoma. Is this clear with everyone? So I can show you the previous picture again. You can see multiple bubbly looking cells out here, over here, multiple bubbly looking cells. Similarly, you have bubbly looking cells out here. Same over here. All of them look empty. So bubbly cells, chordoma, what are these cells? They are the ficelliferous cells. Okay, before I end the session, I hope no one's bored up till now. I know we've extended it a little. But before I end the session, this is your last slide for the day. We've spoken so much about bone, trabeculae, osteoid, cartilage. We forgot the bone marrow. This is the bone marrow. Anything that comes to your mind when you look at this. This is the last one. Anything that comes to your mind when we look at this, it's a bone marrow and it's showing me this finding. It's showing me, yes, a lot of RBCs, blood, fine. What else? So I open it for discussion. What else do you see out here? It's a very classical, if I would have told you history, then all of you will be telling me the answer within a minute. Okay, Dr. Pankaj says, no, every bone marrow that we see will not be CML. Don't think that I've shown you bone marrow, it has to be some hematological problem only. Anyway, if it would have been CML, what would you have seen? You would have seen garden party appearance. You would have seen lots of myeloid lineage cells. Here I'm not seeing. Here what am I seeing? I'm seeing cells which are totally empty, white cytoplasm and nucleus. Okay, do you all agree that they are clear cells? This much everyone agrees, they are clear cells. Can we come to this conclusion together? That they are clear cells? Okay. Okay, someone says multiple myeloma. Why multiple myeloma? Multiple myeloma will show you plasma cells. These are not plasma cells. If I would have said this was a 50-year-old female with a renal mass, a 50-year-old female with a renal mass and the bone marrow biopsy is showing you this. Bone marrow, like I said, all of you are thinking only in terms of hematological problems. You're not thinking that maybe something else can also come to the bone marrow. Bone marrow can show you metastasis, yes. Clear cells, kidney mass, I've already told you, female has a kidney mass And then she's showing you these kind of clear cells in the bone marrow. This was actually a case of metastasis of clear cell RCC in the bone marrow. All of us know that kidney can show bony metastasis, yes? So yes, this was a case of clear cell renal cell carcinoma. Everyone knows clear cell RCC is the most common variant of RCC. Yes, that can show metastasis. So this was a case you had to correlate, right? Every bone marrow picture is not a hematological problem. That is what you've learned today. You have to look at the history very carefully. If they've given you a 45, 50-year-old female with a renal mass is mentioned, and maybe they've written that the renal mass is showing you some very clear cells that are present, or maybe they've told you a syndrome which may be associated with clear cell RCC. What is the syndrome associated with clear cell RCC? Von Hippel-Lindau syndrome. So maybe they've told you about that, and they have given you this bone marrow picture. So this was a case of metastasis of clear cell RCC. So take home message, every biopsy of the bone marrow is not a hematological condition. Right? Are we clear on that? So yes, with that, our basic images, yes, I would still call it very basic because I have not discussed theory. We've only gone in for the images because that is what this session is all about. So I give you probably a week's time to all of you to read through Robbins or whichever book you are going through. And I give you time to revise these images. I'll be giving you the PDF also, so you can always revise that. And thereafter, we'll conduct a free class on Unacademy where we will discuss MCQs. Then we won't do theory proper, like, reading theory. We'll discuss it with the help of MCQs, and then we will apply all this knowledge over there. So yes, you have that much time to go through your notes and revise your images. So well, that is it for today. Let me tell you, tomorrow, this is specially for the dear second year students, because a lot of students have written to me that ma'am, how to study Robbins, and I think that's a question which is very tough for me to answer. So basically, I can't tell you how to study Robbins, but how to study pathology in second year, especially if you have exams coming up or if you just started with second year. So for the second year students, especially tomorrow, how to study Robbins. Tomorrow at 6 p.m. I'll just give you a small briefing of what are the do's and the don'ts if you're in your second year, because I've got so many queries on this. It's very difficult to explain to everyone over Telegram or Facebook or chat windows. So I guess a short discussion of 15-20 minutes with all of you will certainly be beneficial for you, right? So tomorrow at 6 we'll meet, and I've just got one small plan which will really help you decode a vast book like Robbins, and also other things that you have in second year that you have to do, right? Okay, thank you guys. Thank you so much for joining in, and great interacting with you, some great answers, and all of you, as I always say, you pretty much know it all. I always wonder every Tuesday whether I should continue with this series, because I always feel that you give such good answers, but then most of the Tuesdays we do end up continuing it. So thank you so much for joining in, and second years, see you tomorrow sharp 6 p.m. Let's have a short discussion over pathology.